David, you brought up a great point, and really this takes us to our last topic, which is the identification and prevention of skeletal-related events that's caused by bone metastases due to metastatic prostate cancer. We know that over the past 2 years that there has been a new agent that has been approved for the prevention of skeletal-related events, which is denosumab or Xgeva. Prior to that, the only other agent that was approved in that space was zoledronic acid. So, and again, as sort of, again, using that as a backdrop for a discussion, and obviously this relates to our previous discussion about the importance of urologists recognizing bone health. Now we're going to talk a little bit about the effect of bone metastases in terms of how it affects the patient population, and more importantly, how we as the urologist can be more actively engaged. Mark, tell us your thoughts about how you believe urologists ought to be more involved in this disease state in terms of skeletal-related event prevention.
Dave touched on it, and I think it's true when you're talking about identifying metastases early. Then you have to look at PSA doubling rates, like Neil suggested. The doubling rate, I think, for castrated patients is going to be different, and you have to look at it differently, and the total volume is going to have to be much lower than you're used to looking at. And look for it early. Do your bone scanning probably sooner than you normally would. For prevention, I think that that's a little harder. We talked about calcium and vitamin D and exercise. I think all of those are extremely important. And I've been using a lot more Prolia, which is the little brother to Xgeva, denosumab, and in the patients I think that are at risk. And so we've been incorporating that with our early androgen deprivation as a part of routine. So those are the things that we're doing. I mean,
I think it's been pretty clear that all of us have busy practices, and I think, as you mentioned in the Zyba-T10 trial, is that a full 30 to 40% of men who were thought to be CRPC-M0 in fact had unrecognized M1 disease. And I think it's been pretty clear, talking to my partners, reviewing a number of charts, is that what tends to happen in our busy clinics is that the patients come in, they're stable, and unfortunately we ask the wrong question is, well, how are you feeling and are you having any pain? And if they're not having any pain, we give them their shot, we say, see you in 4 to 6 months, get your PSA walking out. And it's like we all know, all the studies indicate that, again, the absolute value of PSA is just not a good indicator. And I think we need to sort of get into the mindset that the strategies, the mechanisms that we use to follow hormone-naive, early-stage prostate cancer are not the same mechanisms and monitoring schemes that we have to use in this advanced prostate cancer state. And I think that's a big educational challenge for those of us as thought leaders to get out within the field of urology, and obviously the first place to start is generally our own partners. Paul, again, you've been very, very active in clinical trials. You've been very active in the bone health world. Your thoughts about SRE prevention and the importance for the urology community to be involved.
I think it's all education. You're right. I mean, I think people just are not used to looking at PSA velocity or PSA doubling time. And that's what we've incorporated. I think Dave mentioned the Zyba-T10. It was the same thing in the Xgeva bone met prevention study, that another population similarly thought to not have bone metastasis, and they found almost a quarter of the patients that were presumed to be bone scan negative were bone scan positive. So I think we underestimate the disease. It's there, and I think the exciting thing going forward for us is we're starting to incorporate PET scans fused with bone, the sodium fluoride PET, to get an answer to say, oh my gosh, these guys have earlier metastatic disease than we even appreciated before. And that's going to be the game changer for us, because we're going to identify people. Bone scans are a relatively insensitive test, and that's going to be very interesting, and we're starting to incorporate that. But we clearly, in our ADT clinic, have our nurse practitioner focused on get the doubling time, let the guys know this guy's at risk. Yes, PSA still looks pretty good, but his doubling time is worrisome. Go look, it'll be there.
Neil, any thoughts on how we build consensus?
I like the way you touched on the concept of prevention. You know, it is all about, you know, looking and being proactive and not waiting for a patient to necessarily come in and say, hey, you know, what's happened in the interval time? Oh yeah, I saw my orthopedist, I had a fracture. And most times if they did, they may forget to tell you. But it's for us to be more proactive in our preventative strategies, whether it be, you know, ADT toxicities, but also in our M0 CRPC patients, looking for effective, appropriate scanning, because we now have therapeutics to offer them, whether it's Provenge as an immunotherapeutic, possibly, and now with level 2B NCCN guideline recommendation for abiraterone, and almost certainly in the future other oral agents such as enzalutamide. Dave mentioned radium-223, which is an alpha isotope, which is very well tolerated, not yet approved, but phase 3 data showed decrease in SREs and also prolongation of survival. So these are things that we have to be more proactive about. I completely agree, and I think it's great that we're getting a lot of sponsorship of education. It is all about education, and we can learn new things. You know, we're not all old dogs. We can, you know, get and understand new therapeutics and new pathways. And if we don't, we will, I think you said this earlier, we'll be marginalized. And somebody else is going to do it, whether it's an endocrinologist or a radiologist or the internist or a medical oncologist. And I think we're perfectly poised now to do it.
Well, gentlemen, thank you for your time today, and I think this has been a very valuable discussion. I know hopefully the audience will take away as much from this, I know, as I have. These are always great discussions in a very open format. That's really all the time we have for today's discussion. I'd like to thank everybody again for being here. We hope our viewers found the conversation informative and helpful, and we invite you to visit onclive.com for more of urologists and cancer care. Hopefully this will be the first of many, many more of these interactive discussions. Our next OncLive TV peer exchange program will include a number of topics of importance to urologists and cancer care, including many of the things we talked about today, which is the FDA review of enzalutamide, the radium-223 pending FDA submission this summer, as well as a number of different other therapeutics, as well as updates from various meetings locally as well as around the world. So thank you again for joining us, and we look forward to seeing you soon.